So Sjogren syndrome is a chronic autoimmune exocrinopathies in the salivary glands and the labial glands. So there will be the destruction of the salivary and the lacrimal glands, resulting in the dry mouth, that is the xerostomia, and the dryness and atrophy of the conjunctiva and the cornea. So that is the xerophthalmia or the keratoconjunctivitis sicca. Okay. So you will find that in the presence of the dry mouth, these people will get lot of the caries teeth and the oral candidiasis. So these are very common in those people with the dry mouth, xerostomia. Okay. So it was first coined by the Swedish ophthalmologist Sjogren, who first described it in 33. It is an immune disease, immune mediated inflammatory disease of these glands with or without internal organ involvement. So like any autoimmune disease like your lupus etc., almost all the internal organs will be involved here. So ranging from the pleura, parenchyma, lungs, heart, okay, kidneys, gut, etc. It is of the two types usually, primary and the secondary. So primary one is a pure autoimmune disease characterized by SSA and SSB, okay, or anti-Rho or anti-law antibodies. And secondary is not that common. Secondary is usually associated with other autoimmune diseases, and most common, the three diseases are very commonly associated here are the rheumatoid arthritis, lupus, and systemic sclerosis, also called as scleroderma. Etiology, like any other autoimmune diseases, are more common in the females in the ratio of the 9:1, and I think the only one or two diseases are common in males as far as these diseases are concerned. One is ankylosing spondylitis. So that is more common in the males, and the second one is almost equivalent to the male and the female ratio is the psoriatic arthritis. So that is 1:1, whereas all other diseases are mostly caused in female gender. So it is most common in the 4th and the 5th and the 6th decades, and it is an imbalance between the genetic and the environmental factors. So some environmental factors will trigger those people who are genetically predisposed to have these autoimmune diseases. So here HLA-B8, DR3, although DR4 is more closely associated with the syndrome occurring with the Raynaud's phenomenon. So when the Raynaud's phenomenon is very common with systemic sclerosis or scleroderma. So antibodies to the Rho antigen occur in the excess of the relatives of the patients with the Sjogren syndrome. The pathogenesis is always a multifactorial. Exact cause is not known even today. Known to be the autoimmune, but studies suggest that the disease process has a genetic, environmental, especially your virus, Epstein-Barr virus, Hep C, Hep B, HIV, etc. And also the hormonal associated with the high prevalence in the women, especially the estrogen. These are environmental factors, and other environmental factors, as I told earlier, the smoking is a big environmental factor for the autoimmune diseases, and air pollution is also a big environmental factor for the autoimmune diseases. See the environmental factors: activation of the glandular cells, HRDR independent immune system, and there will be the alteration of the glandular vascular endothelium. So that the chemokines and the receptors, you have the pro-inflammatory cytokines and the anti-inflammatory cytokines. This is an imbalance between the pro-inflammatory cytokines and the anti-inflammatory cytokines, resulting in the immune dysfunction. Maybe the impaired secretion due to the glandular dysfunction, activation of the lymphocytes, etc. So these are all very common as far as the pathogenesis is concerned. Here the lymphocyte and the plasma cell infiltration, auto-antibody production to Rho, and also the LA, a connective tissue proliferation, a glandular cell apoptosis, atrophy of the glandular structures in the affected tissues, the salivary glands, sebaceous glands, sweat glands, etc. And some secondary changes like edema of the conjunctiva. So it's a good presentation as saying the glandular manifestation has the dry mouth. It's due to the decreased production of the saliva by the salivary glands. See, most of the people know they secrete nearly 5 ml in 15 minutes. But whereas in this population, they secrete less than the 1 ml in 15 minutes. So that leads to the lot of dry mouth. Okay. See the cracked, peeling and atrophic appearance of the lips, and also the dry and the fissured tongue. So these are the features in Sjogrens, and these people are more prone for the caries teeth and the fungal infections. See the teeth, multiple caries and the early loss of the teeth. The chronic oral candidiasis is also frequent, and parotid gland enlargement. Here it is a unilateral on the left side, on the right side it is a bilateral parotid gland enlargement. See the lacrimal gland involvement. Dryness of the eyes causes the keratoconjunctivitis sicca and the burning itchy sensation in the eyes. See the edema here, the upper eyelid edema. So these are the very common here. The parotid gland enlargement is also here. It is almost like a spotter. So you have to suspect Sjogrens when you see such people. And they open the mouth, they will have some caries teeth, dry mouth, etc. The skin manifestations, these people will have the geroderma, pruritus and the scaling, annular erythema, papular erythema including the sweats-like lesions, Raynaud's phenomenon, mostly in the secondary Sjogrens associated with the scleroderma, hyperglobulinic purpura, vitiligo, sweating abnormalities, cutaneous amyloidosis, alopecia, either the diffuse or the generalized. So these are the most of the skin manifestations we often see in the Sjogrens. So other manifestations, arthralgia and arthritis are the very common here. Arthralgia is simple pain in the joints, and arthritis is pain plus swelling is arthritis. Myalgia and the myositis, the same thing here. The muscle pains is the myalgia. Myositis is inflammation. So where you have the CPK and been elevated, etc. And you should diagnose this myositis by biopsy of the skin or muscle biopsy. So in the ENT you will have the sinusitis and the hearing loss. GERD is very common here because of the dryness of your esophagus or dryness of the trachea, dryness of the larynx. So these are all will lead to these sinusitis, hearing loss, and also the GERD. And respiratory systems, you will have the interstitial pneumonitis, pulmonary fibrosis, and pulmonary hypertension. Interstitial nephritis and renal tubular acidosis, these are very common in nephrological point of view. And in the neurological involvements, you will have the migraine, vascular headaches, neuropathies, either the cranial neuropathies or the peripheral neuropathies, and cerebral vasculitis. See, it's an autoimmune disease, so the vasculitis is very, very common. So in a young fellows who got the CVA, so definitely one differential diagnosis could be a autoimmune disease, either a lupus or a Sjogrens or the rheumatoid or systemic sclerosis, etc. It's a very common association with these things. Then we consider as the secondary Sjogrens. So most common is the rheumatoid arthritis, lupus and scleroderma. So these three about 80% of the cases, and sometimes it may also presented with the mixed connective tissue disorders, primary biliary cirrhosis, myositis, vasculitis, thyroiditis, a chronic active hepatitis, and mixed cryoglobulinemia. High index of suspicion must be there to diagnose it, because most of these cases we diagnose on the history and only few investigations to clinch the diagnosis. So Sjogren syndrome patients of both primary and secondary have marked hypergamma-globulinemia, so G more than A more than M. ANA is related in the total protein and the sedimentation rate also. So ANA will be the positive not only in the lupus but also in most of the other autoimmune diseases you will be the positive. When the ANA is negative, you are not dealing a case of the lupus, but ANA positive, it could be a lupus, need not be always a definitely lupus. So to consider the lupus along with the ANA positive, so you will have a double stranded DNA or anti-SM antibodies or anti-URNP antibodies. So they are more specific rather than the sensitivity. Anti-Ro and anti-La antibodies occur in approximately 60% of the patients with Sjogren syndrome, not 100%. Histology of the skin shows an absence of the sebaceous glands and decrease in the sweat glands. So usually you don't require the skin biopsy. So this is the biopsy of the labial salivary glands. See the lymphocytic infiltration and the plasma cell infiltration. Skimmer's test is a very useful test to diagnose the Sjogrens. He is a German ophthalmologist. It determines whether the eye produces enough tears to keep it moist. So the test is used when a person experiences very dry eyes. or excessive watering of the eyes. So this is it places a small strip of the filter paper inside the lower eyelids, that is the conjunctival sac. The eyes are closed for the 5 minutes. The paper is then removed and the amount of the moisture is measured. So on the paper you will have the measurement of this moisture, whether it is a 3, 4, 5, 10, etc. like that. So this technique measures the basic tear function. A young person normally moistens 15 mm of each paper strip. Because hypolacrimation occurs with the aging, 33% of the normal elderly persons may wet only 10 millimeters in 5 minutes. Usually it is a 15 millimeters. In elderly, it may be only 10 millimeters. But persons with the Sjogren's moist less than the 5 millimeters in 5 minutes. So when you apply that paper, you see it after the 15 minutes. So it should be less than the 5 mm to diagnose as the Sjogren syndrome. If it is 15 in 15 minutes, so definitely it is not a Sjogren's. So the normal, which is more than the 15 minutes wetting of the paper after 5 minutes, mild between 14 to the 9 millimeters of the wetting, moderate 4 to 8 millimeters of the wetting, and severe less than the 4 millimeters of the wetting of the paper after keeping that in the conjunctival sac for 5 minutes. See, this is the paper and that is the scale, and then how to read it. So it is another test is the rose Bengal dye, purple rose Bengal staining here. The weight of the eye normally should not take up the any stain. Even though there is no deficiency of the tear production, the eye is dry because the tear film. It is a criteria, the revised criteria for the Sjogren's for your diagnostics. The ocular symptoms, at least one of the dry eyes for more than the 3 months, sensation of the sand or the gravel in the eyes, need for the tear substitutes more than the 3 times a day. So you have the cellulose tear drops, so they apply it more than the 3 times a day for the dry eyes. These are the ocular symptoms, so at least for the 3 months. Oral symptoms, dry mouth for more than the 3 months, recurrent or persistently swollen the salivary glands, need liquids to swallow the dry food. So they keep on taking the more and more liquids, so they are thirsty. Ocular signs, at least one of the following 2 tests would be positive. So they are the symptoms. Ocular symptoms is the dryness, where the sign, the Schemmer's test or the rose Bengal test. And histopathology not in all cases, but in some cases when you are in a doubt, so better to go for the salivary glands histopathology, the focal lymphocytic hyaluronidase. Salivary gland involvement, a positive result for at least one of the following diagnostic tests. Unstimulated whole salivary flow, parotid xylography showing the punctate, cavitary or destructive pattern without evidence of the obstruction in the major ducts. Salivary scintigraphy shows delayed uptake, reduced concentration, and usually we don't do this when you are in a doubt, so because it's mostly the history, the diagnosis. So the dry eyes, the dry mouth, your Schemmer's test, and rare sometimes the biopsy, you will clinch the diagnosis. And most important is your antibodies, autoantibodies, anti-Rho and anti-La. They will be positive in more than the 60% of the cases of the Sjogren syndrome. So what are the criteria for the primary Sjogren's or the secondary Sjogren's? For primary Sjogren's, in patients without any potential associated disease, a primary SS may be defined as follows. The presence of any 4 of the 6 items is indicative of the primary Sjogren's. As long as their item 4, the histopathology, or the 6th, the serology, is the positive. So mostly the serology is the positive, that is the 1 point, and another 3 points is the dry mouth, dry eyes, and your Schemmer's test positive. Those 3 are the positive, your anti-Rho and anti-La is positive, then your diagnosis is the primary Sjogren syndrome. So you need not wait for your salivary gland biopsy, etc. The presence of any 3 of the 4 objective criteria items, that is item 3, 4, 5, 6. So what is 3, 4, 5, 6? So 4 is histopathology, 5 is salivary gland involvement, autoantibody is the 6, they are written only the 3. So these 3 are these things. For secondary Sjogren syndrome, in patients the potentially associated diseases like your rheumatoid arthritis or the lupus or systemic sclerosis, the presence of the item 1 or item 2 plus any 2 from among items 3, 4, 5 may be considered as indicator of the secondary Sjogren's. So item 1 is dry mouth, dry eyes, item 2 is dry mouth, and the 3, 4, 5 is your skimmer's test or histopathology or salivary gland examination, and 6 is the antibodies positivity, anti-Rho and anti-La antibody positivity. So what is the treatment for this Sjogren syndrome? It is mostly a symptomatic treatment for dryness of the eyes. So we use the lubricating agents. So mostly the methyl cellulose eye drops. So by brand name Tears eye drops, they are very popular. So that is methyl cellulose eye drops. So you ask them to apply for at least 3 to 5 times a day. Cyclosporin ocular drops are also there because in an autoimmune disease, the cyclosporin as an anti-immunosuppressive agent. So they also can be useful here. The bromoxin 16 milligrams TDS has been found to increase the lacrimal secretion. Artificial saliva or the cyclosporin for the xerostomia, and routine dental care when they are having the caries teeth, and steam inhalation may help dryness of the respiratory tract. Candidiasis, as I told you, very common here. Here you can use the topical nystatin 3 times a day for a week. In the systemic, some people they make you are supposed to use the ketoconazole 200 to 400 milligrams per day, or fluconazole 50 to 100 milligrams a day, or itraconazole 100 milligrams per day for 2 weeks, not 3 days or 5 days. So here, as an autoimmune diseases, you need to use for a longer period, at least for the 15 days period. Systemic steroids are effective in reducing the parotid swelling, not in all cases. In some cases, we use the systemic steroids. See, as you know that steroids are the double-edged weapons. So when the fellows are also associated hypertension, diabetes, so better not to use the steroids at a maximum dosages. Hydroxychloroquine is a very useful DMRD here. 200 milligrams daily is always useful. So hydroxychloroquine is a very useful drug in lupus and also in Sjogren's. Causes of the dry mouth and the dry eyes. So what are all the causes of the dry mouth? So some drugs will cause the dry mouth, especially the common drugs we use are the diuretics, beta blockers, tricyclic antidepressants, ARBs, antihistamines. So these are the common drugs we often use in our routine practice. Antihistamines, ARBs like your telmisartan, vormisartan, isilsartan, losartan, and tricyclic antidepressants, your imipramine, etc. And the beta blockers, maybe vasodilatory beta blockers or your traditional beta blockers like propranolol or etinolol, metoprolol, bisoprolol, carvedilol, nebivolol. So these are all will cause a dry mouth. And the diuretics, so thiazide diuretics or thiazide-like diuretics like chlorothalidone, or the loop diuretics or potassium sparing diuretics, etc. So they also will cause, these are common drugs which cause the dry mouth. So the diuretics, antihypertensives, beta blockers, antihypertensives, ARBs, antihypertensives. So most of the times now in the chronic hypertension population, we use a 2-drug combination or the 3 drugs combination. And uncontrolled diabetes, so almost like in a type 1 diabetes. So they also will have your classical 3 Ps. So polyphagia, polydipsia, polyuria. So here you have uncontrolled diabetes, you have the dry mouth. So they keep on taking the more and more liquids. Otherwise, these people will go into the DKA, in dehydration. Head and neck radiations, that is the post radiation. Mouth breathing, some people they are mouth breathing. Psychological causes, and IgG4 disease and sarcoidosis. So out of them, the common are the drugs. Uncontrolled diabetes is a very common, and of course the mouth breathing and psychological causes in some population. What are the causes of the dry eyes? So the dry eyes, Sjogren's is the one cause here. The sarcoidosis is also very common. Lymphomas, elderly, diabetes, facial nerve palsy because of the exposure, dry eyes, exposure keratitis. The drugs, same drugs causing the dry mouth, they also cause the dry eyes, like your diuretics, beta blockers, ARBs, tricyclic antidepressants, antihistamines, etc. Lid and ocular surface diseases. So these are the causes of the dry mouth and the dry eyes. Not all the dry mouths and the dry eyes are caused by the Sjogren syndrome. So before the Sjogren's, as a physicians, we always think of the drug-induced causes because a lot of the people will use these drugs in our routine practice. The classification, as I told you, the primary where the exact cause is not known, secondary usual associated with other autoimmune diseases, and organ-specific autoimmune diseases like primary biliary cirrhosis, thyroiditis, multiple sclerosis, diabetes, that is autoimmune diabetes or type 1 diabetes. Infections, Hep C, HIV, and also HTLV1 infections. So these are other associations. Extraglandular systemic features in the Sjogren's. So what are all the features here? Cutaneous manifestations, musculoskeletal involvements, vasculitis, respiratory system, renal involvement, peripheral nervous system, CNS, and hematological features. See, they have given the prevalence of these diseases to association. If you see the cutaneous manifestations, about 10 to 15%, mostly the purpura, urticaria, or the pruritus. If you see the musculoskeletal involvement, maybe 15 to 30%. So symmetric, non-erosive inflammatory arthritis, like your lupus. Lupus is also non-erosive. Suppose if you take a rheumatoid arthritis and erosive, and if you take a psoriatic arthritis, so that is also very erosive. Okay, here it is a non-erosive like your lupus. This is a non-erosive inflammatory arthritis. In the vasculitis, 10 to 20% they will have a Raynaud's phenomenon. And the respiratory system, 5 to 10%, they have the dry cough because of the dry mouth, recurrent bronchitis, salivary, small airway disease, and interstitial lung diseases. Renal involvement, yes, tubular interstitial nephritis, or renal tubular acidosis, distal renal tubular acidosis, and peripheral neuropathy, subacute encephalopathy. And in the hematological, you will have the anemia, neutropenia, thrombocytopenia, cryoglobulinemia. Risk factors for the lymphoma in Sjogren's. So these are more prone for the lymphomas in some individuals. So what are the risk factors? So these people with severe parotid involvement, so more chances of going into the lymphomas. Again, the more purpura, cryoglobulinemia, low complement levels, your C3 and C4 levels at a lower level, severe leukopenias. So when your WBC is less than the 500 or less than the 1000, and anti-law antibody positivity, not the anti-Rho antibody positivity. Anti-law antibody positivity people will more prone for the lymphomas. See, this is the Schimmer's test. Drugs useful for the sicca symptoms in the Sjogren's. So the tear or saliva substitutes, we have the methyl cellulose, etc. And the topical cyclosporin eye drops, pilocarpine, cervimeline, N-acetylcysteine, hydroxychloroquine. In some cases, when the involvement of the lung, involvement of the gut, involvement of the kidneys, so you can use the rituximab. Rituximab is a very useful drug in the Sjogren's in some people where they have multi-organ involvement. Drugs used for the extraglandular manifestation of the Sjogren's syndrome. Here you can use the methotrexate when the fellow is having arthritis and the fatigue. When the fellow is having interstitial lung disease, you can use the azathioprine. When the fellow is having the lung and the renal disease, mycophenolate. And vasculitis, glomerulonephritis, and mononeuritis, cyclophosphamide. So these 4 drugs can be used in the Sjogren's when they associate with the other things. Suppose the arthritis is more prominent, you can use the methotrexate. When the ILD is more prominent, you can use the azathioprine. So when the lung and the renal disease is more common, when the mycophenolate, when the vasculitis, the cyclophosphamide. So thank you very much.